I am here this afternoon to talk about this combination that we've seen of these two pandemics. I happen to sit in a health system where I've seen the consequences of both COVID-19 as a pandemic and certainly racism and the effects that it has had in our country and in our community during this COVID-19 pandemic. I specifically want to talk about the issue of racial equity and how to center racial equity in vaccine allocation. So I will be talking to you today about some of the work that we have been doing at UW Health as an academic health system in Madison, Wisconsin, in trying to really center the issue of racial equity as we think about vaccine and vaccine allocation and distribution. So at UW Health, we have taken very seriously our mission of being a leader in dismantling racism in ourselves, in our system, and in our community. And it is through this vision that we decided from early on in our conversations about vaccine and vaccine allocation to really think about using an equity lens and an anti-racist lens in the way that we were going to be dealing with distribution and access to COVID-19 vaccine. So what does it mean to really center racial equity in our vaccine efforts and distribution? First, it is an acknowledgement of the fact that we know that racism has a direct impact in the disproportionate impact of COVID-19 on our communities of color. We have seen that we have had a higher risk factors and higher impact and hospitalization and death rates among our communities of color due to COVID-19. And that really is the result of decades and decades of systemic racism that have really created the social environment to make this virus attack really our communities of color in much higher rates. We have also seen that the issue of access to COVID-19 vaccine has continued to perpetuate some of the divisions and racism that exist in our communities. We have seen scarcity of availability of vaccine and therefore an access to vaccine for those people who are in positions of more privilege and power. And trust is certainly an issue around vaccination. Again, our communities of color have had a history of lack of trust in systems, including in health systems and in government. So trusting the information that's provided about the vaccine and the safety of the vaccine has been another aspect of COVID-19 vaccination efforts. So as we look today at our vaccination rates right here in Dane County, Wisconsin, we can see that we continue to have disparities in our vaccination rates. Again, really confirming the fact that access to the vaccine is a critical issue that we need to address. So although we have 59% of our white non-Hispanic residents in our county vaccinated, with at least one dose of COVID-19 vaccine, our Black residents rate is at 28%, and our Hispanic and Asian community residents rate are around 41 to 43%. One success story is really the vaccination rate for our Native American or American Indian communities. In addition, as we look at the trend of vaccination over the past 3 weeks by race and ethnicity, we can really see very quickly that there continues to be a very positive and significant growth in vaccination rate among white non-Hispanic, while that growth is certainly in percentage not as significant for our Asian, our Latinx, and our Black communities. So what can we do about this? What have we done about this? So I want to tell you a little story over the past 5 months of what can happen when one really prioritizes equity and really thinks about racial equity as a center of decision-making around vaccine allocation. So back on December 14th of 2020 at UW Health, we received our first shipment of COVID-19 vaccine, Pfizer. And at the time, the eligibility included all our frontline healthcare workers and staff and residents of long-term care facilities. We knew that we were not going to have enough vaccine to be able to vaccinate everybody at the same time, right? And that this was going to be taking at least a few weeks, if not longer, depending on the supply of vaccine. So we decided that we were going to have to prioritize and prioritize based on job-related exposure, on age, because we know that age is definitely a factor in higher risk of hospitalization and death on COVID-19. And we also made the decision to add social vulnerability index to our algorithm that we use to prioritize. Again, this would be prioritizing our own healthcare workers that were in the eligible category. So social vulnerability index, for those who are not familiar with it, is actually an index created by the CDC and that considers 15 social factors that create really a vulnerability and identification and mapping of communities that will most likely need support. And again, it's used usually during national disasters and certainly has been talked about a lot during COVID-19 as one of the indexes that can be used to identify which areas have the highest risk. So one of the factors that was used in the social vulnerability index is actually race and ethnicity with the category of minority status and language. So we know that communities with greater social vulnerability are more likely to be COVID-19 hotspots and have increased case counts. That is why we decided for our employees who were eligible at the time back in December again for the COVID-19 vaccine to really use an algorithm that included social vulnerability index. When we looked at how we used our algorithm, and again in the algorithm we use job exposure, age, and social vulnerability index, we could see that with the individuals with the same job exposure to COVID-19, when we were using social vulnerability index, we started to be able to shift employees with social vulnerability index to get their vaccine earlier in the distribution quartiles. So it really demonstrated to us that using an algorithm that took into account those who we knew were at higher risk because of their SVI or social vulnerability index did actually work. Then we moved in February to kind of the second phase of vaccination in the US, which was the eligibility that was expanded to those individuals who were ages 65 and older. So at that point, what we decided to do at UW Health is to really think about how we were going to reach all of the individuals that we had who were primary care homed within our system and were 65 plus. And we had over 55,000 of those individuals that were 65 plus and primary care homed within our system. And we knew we're not going to get 55,000 vaccines right away. So when we looked at the risk factors for individuals and looked at our patient population and the data that showed that unfortunately being Black, Latinx, and Native American created a higher risk for individuals, we decided that we were going to send invitations to have their vaccine as a priority first to our Black, Latinx, and Native American patients, and then the subsequent prioritization for the other populations was by age, so from older age to 65. The results of that have actually shown to be really effective because as we look at our percentage of patients who have been vaccinated that are 65 plus, we now see that our Black, Hispanic, Asian, and white patients are actually at very similar rates of vaccination and at higher less rates of vaccination that we usually see for those population in kind of the larger community. So this really, again, proved that by really thinking about racial equity and making sure that individuals in those higher risk categories had access to vaccine, that those individuals would actually accept the vaccine and be able to get in line and be prioritized. And now, since March, as we all know, the eligibility has continued to expand very quickly to the current state today, where anybody that's 16 plus in the state of Wisconsin, where we are located, is eligible to receive the COVID-19 vaccine. So we are now deploying multiple strategies to try to address and center racial equity. From engagement and education and collaborations across health systems and our public health, Madison-Dane County, with community forums that have trusted subject matter experts. An important piece of trusted subject matter experts is those experts who are really representatives of the communities that they're talking to and have done work previously in those communities that they are part of and are trusted sources. And then we have developed, again, both linguistically concordant materials in different languages and also videos that, again, are both racially and linguistically concordant to do that engagement and education. The second piece of our strategy has been to create vaccine equity days. And these are really days in which we have fully blocked the schedules for one of our clinics that's located in one of the areas that is very diverse area in our city, an area that's very accessible to all individuals in our city. For those of you who are from Madison, that would be on Park Street. So we have decided to reserve 2 full days, mostly a week, in which we're partnering with community organization that serves our communities of color to refer individuals for us to schedule to get vaccinated during those days. The reason that this has been really successful is because it does not rely on the overall system that have been set in place, which requires people to have time and really the ability to usually sit behind a computer and try to sign up for as many places as possible to get in line to get the vaccine. This really creates a direct access to vaccine for the communities, again, that we know have been the most impacted with COVID-19. The third strategy that we've had is around pop-ups and mobile sites where we have had small focused partnerships where we have provided vaccine in a small mobile site, one at this point, and really our thought is to do this in narrow places and ways where we think a mobile site would be better than access to clinic. And last but not least, we also have hired vaccine patient educators. These are community health workers that are part of the Black, Latinx, and Hmong communities that are going to be doing one-on-one outreach to our patients to talk to them about the vaccine, answer any questions that they may have, and have blocked spots within the scheduling for COVID-19 vaccine to be able to schedule those patients if they're ready to get their vaccine. I want to conclude these remarks around how to center and some examples of how to center racial equity in the COVID-19 vaccination process and access by saying that it is a moral imperative, in my opinion, to center our communities of color in COVID-19 vaccination, given the failure that we have seen in the disproportionate impact that COVID-19 had on our communities of color and continues to have on our community of color. So I leave you with a quote by author and Professor Kendi, which is to do nothing in the face of injustice or inequity, so allow the injustice and inequity to persist. And again, we have seen injustice and inequity in many ways over the past year and a half. And one way that we can take action and really do something that is the right thing to do is by making sure that our communities of color have the right access at the right place for COVID-19 vaccine. Thank you.